Biological disease-modifying antirheumatic drugs, BMARDs, are a critical class of treatments in rheumatology. These biologics target specific components of the immune system to modulate inflammatory processes and slow disease progression in autoimmune conditions like rheumatoid arthritis, RA, ankylosing spondylitis, psoriatic arthritis, and others. Types of BDMARDs. 1. TNF inhibitors. Tumor necrosis factor, TNF blockers, such as infliximab, adalimumab, and etanercept, inhibit TNF, a pro-inflammatory cytokine involved in autoimmune diseases. 2. Interleukin IL inhibitors, IL-6 inhibitors. Tocilizumab targets IL-6, an important mediator of inflammation in RA. IL-17 and IL-23 inhibitors, secukinumab and ustekinumab, are examples used in conditions like psoriasis and TSA. 3. B-cell depletion. Rituximab targets CD20-positive B cells, reducing antibody production and inflammation in RA. 4. T-cell co-stimulation inhibitors. Abatacept inhibits T-cell activation, thereby decreasing immune response. 5. JAK inhibitors. Small molecules but often grouped with biologics. Tofacitinib and baricitinib target Janus kinases, enzymes that play a role in immune system signaling. Clinical applications. Rheumatoid arthritis, RA, TNF inhibitors, IL-6 inhibitors, and JAK inhibitors are commonly used when conventional DMARDs like methotrexate fail. Ankylosing spondylitis, TNF inhibitors, and IL-17 inhibitors, like secukinumab, are effective for axial involvement. Psoriatic arthritis. Biologics targeting TNF, IL-17, and IL-23 pathways are commonly employed to manage both joint and skin symptoms. Systemic lupus erythematosus, SLE. Belimumab, a B-cell activating factor F inhibitor, is approved for SLE, targeting B-cell activity. These biologics have transformed the management of rheumatic diseases by not only reducing symptoms, but also slowing disease progression and preventing joint damage. However, their use requires careful monitoring due to potential side effects, including infection risks. Anti-TNF alpha drugs are among the most widely used biological therapies in rheumatology. They target tumor necrosis factor alpha, TNF-A, a cytokine that plays a pivotal role in inflammation and immune regulation. Elevated TNF-I levels are associated with the pathogenesis of various autoimmune and inflammatory diseases such as rheumatoid arthritis, ankylosing spondylitis, AS, psoriatic arthritis, PSA, and inflammatory bowel disease, IBD. Mechanism of action. TNF-A is produced primarily by macrophages, but also by other immune cells like T cells. It binds to TNF receptors, TNFR1 and TNFR2, on the surface of cells, initiating inflammatory processes. Anti-TNF alpha drugs work by neutralizing the activity of TNF-A, thereby reducing inflammation and halting the autoimmune attack on the joints, spine, or other organs. Commonly used anti-TNF alpha drugs. 1. Infliximab, Remicade, a chimeric mouse-human monoclonal antibody that binds to soluble and membrane-bound TNF-A, administered via intravenous infusion, used in RA, AS, PSA, and IBD. 2. Adalimumab Humira, a fully human monoclonal antibody against TNF-I, administered via subcutaneous injection, approved for multiple conditions including RA, ASA, and Crohn's disease. 3. Etanercept Enbrel, a fusion protein that acts as a decoy receptor for TNF-A, preventing it from binding to TNF receptors on cells, administered subcutaneously, used primarily in RA, PSA, and AS. 4. Certolizumab Pegol, Cimzia, a pegylated humanized antibody fragment that binds to TNF-A with the benefit of a longer half-life, administered via subcutaneous injection, approved for RA, AS, PSA, and Crohn's disease. 5. Golimumab Simponi, a fully human monoclonal antibody against TNF-A, administered subcutaneously, monthly, or intravenously every 8 weeks, used in RA, AS, and PSA. Indications. Rheumatoid arthritis, RA. Anti-TNFs are used when conventional DMARDs, such as methotrexate, fail to control disease activity. Ankylosing spondylitis. These drugs are particularly effective in reducing spinal inflammation and improving mobility. Psoriatic arthritis, SA. Anti-TNFs help manage both joint and skin manifestations. Other uses. They are also used in non-rheumatic conditions like Crohn's disease and ulcerative colitis due to their strong anti-inflammatory properties. Efficacy. Anti-TNF alpha drugs are highly effective in reducing symptoms, slowing disease progression, and improving quality of life. These drugs can prevent joint damage in RA and halt the progression of spinal fusion in AS when started early. Adverse effects. 1. Infections. Because TNF plays a critical role in immune defense, especially against tuberculosis, TB, there is an increased risk of serious infections. Before starting anti-TNF therapy, screening for latent TB is mandatory. 2. Malignancies. There is an ongoing debate about the risk of malignancies, especially lymphoma, with long-term use of anti-TNFs, though studies are inconclusive. 3. Autoimmune reactions. Some patients may develop lupus-like syndromes or autoantibodies. 4. Injection-infusion reactions. Infliximab IV is associated with infusion reactions, while subcutaneous drugs, e.g. adalimumab, etanercept, may cause local injection site reactions. Monitoring. Regular monitoring for infections, especially TB, liver function, and blood counts is essential. Long-term surveillance for malignancies is also advised. Switching anti-TNFs. If a patient does not respond to one anti-TNF drug, they may switch to another. Some patients respond better to different drugs within this class due to differences in molecular structure and pharmacokinetics. Anti-alpha drugs have revolutionized the treatment of autoimmune diseases, but careful patient selection and monitoring are necessary to optimize their benefits and minimize risks. Interleukin IL inhibitors are a class of biologic drugs used in rheumatology and other fields of medicine to modulate the immune response. They specifically target cytokines called interleukins, which are signaling proteins involved in the activation and regulation of the immune system. By inhibiting interleukins, these drugs help control inflammation and prevent the immune system from attacking healthy tissues, which is a hallmark of autoimmune diseases. Key interleukin pathways in rheumatology. Several interleukins play significant roles in the pathogenesis of autoimmune and inflammatory diseases, and inhibitors for these cytokines have been developed as targeted therapies. Major interleukin inhibitors. 1. IL-6 inhibitors. Mechanism. IL-6 is a pro-inflammatory cytokine involved in the immune response, and it plays a critical role in the development of chronic inflammatory diseases, particularly rheumatoid arthritis, RA. Key drugs: tocilizumab, Actemra, a monoclonal antibody that blocks the IL-6 receptor, preventing IL-6 from binding to its receptor and triggering inflammation. It is used in rheumatoid arthritis, systemic juvenile idiopathic arthritis, giant cell arteritis, and COVID-19 related cytokine storms. Saralumab, Kevzara, another IL-6 receptor antagonist, similar to tocilizumab, also used primarily in RA. Clinical use. IL-6 inhibitors are particularly beneficial in patients with RA who have not responded well to TNF inhibitors or other biologics. They can reduce joint inflammation, prevent joint damage, and improve physical function. Adverse effects. Risk of serious infections. Elevated liver enzymes and lipid abnormalities. Neutropenia and gastrointestinal perforation, rare. Number 2. IL-17 inhibitors. Mechanism. IL-17 is a pro-inflammatory cytokine produced by Th17 cells, which plays a role in tissue inflammation and bone destruction, particularly in diseases like psoriatic arthritis, A, and ankylosing spondylitis, AS. Key drugs: secukinumab, Cosentyx, a monoclonal antibody targeting IL-17A used to treat psoriasis, PSA, and AS. Ixekizumab, Taltz, another IL-17A inhibitor used for similar indications as secukinumab, primarily psoriatic arthritis and ankylosing spondylitis. Bimekizumab, Bimzelx, a newer IL-17A and IL-17F inhibitor, targeting a broader range of IL-17 cytokines, enhancing efficacy in certain patients with PSA or psoriasis. Clinical use. IL-17 inhibitors are especially effective in conditions with skin and joint involvement, such as psoriasis and psoriatic arthritis. They are also key treatments in axial spondyloarthritis, SSPA, particularly when TNF inhibitors fail. Adverse effects: increased risk of fungal infections, particularly candida infections, as IL-17 plays a role in mucosal defense. Upper respiratory tract infections and injection site reactions. 3. IL-12 and IL-23 inhibitors. Mechanism: IL-12 and IL-23 are involved in the differentiation of T cells and the activation of immune responses. IL-23, in particular, is linked to the Th17 pathway, which is involved in chronic inflammation and autoimmune diseases. Key drugs: ustekinumab, Stelara, targets both IL-12 and IL-23 and is used in psoriasis, psoriatic arthritis, and Crohn's disease. It blocks the shared P40 subunit of IL-12 and IL-23, thereby modulating the immune response. Guselkumab, risankizumab, tildrakizumab, Ilumya. These drugs specifically target IL-23 via the P19 subunit, making them more focused on inhibiting the Th17 pathway. They are mainly used for psoriasis and psoriatic arthritis. Clinical use. IL-12/23 and IL-23 inhibitors are highly effective in treating moderate to severe psoriasis and psoriatic arthritis, offering benefits in both skin and joint symptoms. They are often chosen for patients who do not respond to TNF inhibitors or other therapies. Adverse effects. Risk of infections, including respiratory infections, headaches, upper respiratory tract symptoms, and injection site reactions. Number 4. IL-1 inhibitors. Mechanism. IL-1 is a key cytokine in the inflammatory cascade, particularly in the acute phase of inflammation. It is associated with diseases like gout and systemic juvenile idiopathic arthritis. Key drugs. Anakinra Kineret, a recombinant IL-1 receptor antagonist that blocks the activity of IL-1. It is used in rheumatoid arthritis, systemic juvenile idiopathic arthritis, Still's disease, and gout flares. Canakinumab, Ilaris, a monoclonal antibody that neutralizes IL-1 beta. It is primarily used in periodic fever syndromes and gout. Clinical use. IL-1 inhibitors are not as widely used in chronic autoimmune diseases, but are highly effective in conditions characterized by excessive IL-1 activity, like autoinflammatory syndromes, e.g. familial Mediterranean fever, and acute gout flares. Adverse effects. Increased risk of infections. Injection site reactions, neutropenia, and elevated liver enzymes. Comparison of IL inhibitors versus TNF inhibitors. IL inhibitors target more specific pathways, e.g. IL-6, IL-17, compared to TNF inhibitors, which have a broader immunosuppressive effect. This can result in a more tailored treatment with potentially fewer off-target effects. IL inhibitors are often used when patients fail to respond to TNF inhibitors or when specific cytokine pathways, like the IL-17 axis, are thought to play a larger role in disease pathology. Monitoring and side effects. Patients on IL inhibitors must be regularly monitored for infections, especially respiratory tract infections and tuberculosis, although the TB risk with IL inhibitors may be slightly lower than with TNF inhibitors. Liver function tests, lipid panels, and blood counts may be required depending on the specific interleukin inhibitor being used. Screening for latent tuberculosis, TB, is mandatory before initiating these therapies, as with other biologics. Conclusion. Interleukin inhibitors have become crucial in managing autoimmune diseases, especially in cases where traditional therapies like TNF inhibitors are ineffective. By targeting specific cytokines, they provide tailored treatment approaches for diseases like rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis, with a generally favorable safety profile. However, like all biologics, they require careful patient selection, monitoring, and management of adverse effects. Janus kinase inhibitors, JAK inhibitors, are not classified as biological DMARDs, BDMARDs, but are considered targeted synthetic DMARDs. While BDMARDs are large molecules, often monoclonal antibodies or fusion proteins that target extracellular cytokines or cell surface receptors, JAK inhibitors are small molecules that work intracellularly to inhibit specific signaling pathways. Mechanism of action. JAK inhibitors block the activity of Janus kinases, JAKs, which are enzymes involved in the signaling pathway of many cytokines. These cytokines transmit signals by binding to their receptors, which activate JAKs. This activation, in turn, triggers the JAK-STAT, signal transducer and activator of transcription pathway, leading to the transcription of genes that promote inflammation. By inhibiting JAK enzymes, these drugs can reduce cytokine signaling, thereby decreasing inflammation and immune responses in autoimmune diseases. Key JAK inhibitors. 1. Tofacitinib, Xeljanz, inhibits JAK1 and JAK3 with some effect on JAK2. Approved for use in rheumatoid arthritis, RA, psoriatic arthritis, SAE, and ulcerative colitis. 2. Baricitinib, Olumiant, primarily inhibits JAK1 and JAK2, used in rheumatoid arthritis, and has been explored for use in COVID-19 related hyperinflammation. 3. Upadacitinib, Rinvoq, a selective JAK1 inhibitor, approved for rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and atopic dermatitis. 4. Filgotinib, Jyseleca, a selective JAK1 inhibitor, used in rheumatoid arthritis and under investigation for other conditions like Crohn's disease. Why JAK inhibitors are not considered BMARDs. Size and structure. Unlike biologics, which are large protein-based molecules, like monoclonal antibodies, JAK inhibitors are small synthetic molecules. They are administered orally, while most biologics are given via injection or infusion. Target. JAK inhibitors act inside the cell to block the JAK-STAT pathway, while biologics typically target extracellular components like cytokines, TNF-α, IL-6, or cell receptors. Clinical use. JAK inhibitors are used in patients with moderate to severe autoimmune diseases, especially when conventional DMARDs, like methotrexate, or BDMARDs, like TNF inhibitors, are ineffective or not tolerated. Efficacy. JAK inhibitors have been shown to be highly effective in reducing symptoms, improving physical function, and slowing disease progression in conditions like rheumatoid arthritis. They often provide a quicker response compared to traditional DMARDs and are considered a good alternative or adjunct to biologics. Adverse effects. Infections. Similar to BDMARDs, JAK inhibitors increase the risk of infections, including tuberculosis, herpes zoster, shingles, and other opportunistic infections. Thrombosis. JAK inhibitors have been associated with an increased risk of blood clots, particularly in the veins, venous thromboembolism, VTE. Lipid abnormalities. They can raise lipid levels, so monitoring is required. Hematologic and liver abnormalities. Regular blood counts and liver function tests are recommended during treatment. Monitoring. Patients on JAK inhibitors require regular monitoring for infections, lipid levels, and blood counts, along with screening for tuberculosis, TB, before starting therapy, similar to biologics. In summary, while JAK inhibitors share some clinical similarities with biologics in terms of efficacy and indications, they are not considered biological DMARDs due to their synthetic, small molecule nature and their intracellular mechanism of action. They are categorized as targeted synthetic DMARDs. In addition to anti-TNF alpha and anti-interleukin inhibitors, there are several other classes of biological DMARDs, BDMARDs, used to treat autoimmune diseases. These biologics target various other pathways involved in the immune response and inflammation. Here are key BDMARDs that do not fall into the categories of TNF alpha or interleukin inhibitors. 1. B-cell depletion therapy. These drugs target B cells, which are involved in antibody production and play a role in autoimmune processes. Rituximab mechanism. Rituximab is a monoclonal antibody that targets CD20 on B cells, leading to their depletion. B cells contribute to the production of autoantibodies, which are key drivers of diseases like rheumatoid arthritis and systemic lupus erythematosus, SLE. Indications. Rheumatoid arthritis, RA, often used when patients do not respond to TNF inhibitors or other biologics. Systemic lupus erythematosus, LE, sometimes used off-label for severe SLE. Granulomatosis with polyangiitis, GPA, and other ANCA-associated administration, given as an intravenous infusion. Adverse effects. Increased risk of infections. Infusion reactions. Reactivation of hepatitis B in carriers. 2. T-cell co-stimulation modulators. These drugs interfere with T-cell activation, a critical step in the immune response. Abatacept, Orencia, mechanism. Abatacept is a fusion protein that inhibits the co-stimulation of T cells by binding to CD80 and CD86 on antigen-presenting cells, preventing them from interacting with CD28 on T cells. This blocks T cell activation and reduces the immune response. Indications. Rheumatoid arthritis, RA, used in patients who do not respond adequately to other DMARDs, including TNF inhibitors. Psoriatic arthritis, SA, juvenile idiopathic arthritis, JIA. Administration can be administered via intravenous subcutaneous injection. Adverse effects, increased risk of infections. respiratory infections, headaches, and potential infusion reactions. BL-BAF inhibitors. These drugs target B cell activating factor BAF, which plays a role in the survival and maturation of B cells. Belimumab, Benlysta, mechanism. Belimumab is a monoclonal antibody that inhibits BAF, B cell activating factor, a protein that promotes the survival of B cells. By inhibiting BAF, it reduces the number of B cells involved in autoimmune processes. Indications: primarily used for systemic lupus erythematosus SLE, particularly in patients with active autoantibody positive disease. It is also being studied for use in lupus nephritis. Administration: available as an intravenous infusion or subcutaneous injection. Adverse effects: infections, including serious infections, infusion reactions, nausea, diarrhea, and depression. 4. Complement inhibitors. These drugs inhibit components of the complement system, which is part of the immune response that helps clear pathogens and damaged cells, but can contribute to tissue damage in autoimmune diseases. Eculizumab, Soliris. Mechanism: eculizumab is a monoclonal antibody that inhibits C5, a component of the complement system, preventing the formation of the membrane attack complex, MAC, which can cause cell lysis and tissue damage. Indications: paroxysmal nocturnal hemoglobinuria, PNH, atypical hemolytic uremic syndrome, ACE, approved for generalized myasthenia gravis and neuromyelitis optica spectrum disorder, NMOSD. Administration: given as an intravenous infusion. Adverse effects: increased risk of infections, particularly meningococcal infections, requiring vaccination prior to therapy, headache, fatigue, and gastrointestinal symptoms. 5. S1P receptor modulators. This drug modulates sphingosine 1-phosphate S1P star receptor, which plays a role in lymphocyte migration. Ozanimod, Zeposia, and fingolimod, Gilenya. Mechanism: these drugs target the S1P receptor, preventing lymphocytes from leaving lymph nodes and entering the bloodstream, thereby reducing the number of circulating immune cells that can cause inflammation. Indications: used primarily in multiple sclerosis, MS, but also being investigated for use in inflammatory bowel disease. Administration: oral. Adverse effects: bradycardia, slowed heart rate, macular edema, liver enzyme elevation, and infections. NAR6, anti-IgE therapy. This therapy targets IgE, a type of antibody involved in allergic reactions and inflammation. Omalizumab, Xolair. Mechanism: omalizumab is a monoclonal antibody that binds to IgE, preventing it from attaching to mast cells and basophils, thereby reducing allergic and inflammatory responses. Indications: approved for chronic spontaneous urticaria and severe allergic asthma. Being explored for use in some autoimmune diseases. Administration: given as a subcutaneous injection. Adverse effects: anaphylaxis, rare but serious. Injection site reactions, headaches, and increased risk of infections. 7. Anti-integrin therapy. These drugs target integrins, proteins involved in the movement of immune cells across the endothelium into tissues. Vedolizumab, Entyvio. Mechanism: vedolizumab is a monoclonal antibody that blocks the interaction of a B7 integrin on lymphocytes with its ligand MCAM1, preventing lymphocyte migration to the gut, which reduces inflammation in the intestines. Indications: primarily used in inflammatory bowel disease, IBD, including Crohn's disease and ulcerative colitis. Administration: given via intravenous infusion. Adverse effects: risk of infections, especially respiratory and gastrointestinal infections, headaches, arthralgia, and infusion reactions. Conclusion: biological DMARDs have revolutionized the management of autoimmune diseases by specifically targeting key components of the immune system. Beyond TNF alpha and interleukin inhibitors, other biologics like B cell depleters, T cell co-stimulation modulators, and complement inhibitors have provided more options to tailor treatment for different autoimmune and inflammatory conditions. Each class of biologics targets a specific part of the immune system, offering precision in managing complex diseases, but also requiring careful monitoring for infections and other potential adverse effects. Biosimilars overview. Biosimilars are biological drugs that are highly similar to an already approved originator biologic, also called the reference product, in terms of safety, purity, and efficacy. They are developed after the original biologic's patent expires, offering a more affordable option for treating various diseases, especially in the field of rheumatology, oncology, and gastroenterology. Idea behind biosimilars. The concept of biosimilars was introduced to provide cost-effective alternatives to biologics, which are often expensive due to the complex manufacturing processes. Since biologics are large, complex molecules produced by living cells, they cannot be precisely replicated like small molecule drugs, generics. Biosimilars are designed to be highly similar, but not identical to the original biologic. Patency of originator drugs. 1. Patency protection. Originator biologic drugs are protected by patents, which typically last around 20 years. During this time, no other company can produce the same drug. After the patent expires, other manufacturers can develop biosimilars. 2. Exclusivity period. Apart from patent protection, biologics often enjoy a period of market exclusivity, usually around 12 years in the US, during which no biosimilars can be marketed, even after patent expiration. Advantages of biosimilars. 1. Cost reduction. Biosimilars offer cost savings compared to originator biologics, making life-saving treatments more accessible to a wider population, particularly in chronic diseases like rheumatoid arthritis and psoriasis. 2. Increased access. By reducing healthcare costs, biosimilars increase patient access to biologic therapies, improving overall patient outcomes in the management of autoimmune diseases, cancers, and other conditions. 3. Competition and innovation. The introduction of biosimilars stimulates competition, which may drive innovation and further reduce prices of both biosimilars and originator biologics. Precautions with biosimilars. 1. Regulatory approval. Biosimilars must undergo rigorous testing to prove they are highly similar to the reference biologic in terms of safety, efficacy, and quality. However, they do not need to replicate the entire clinical trial process for all indications, leading to cost savings. 2. Immunogenicity. One of the concerns with biosimilars is immunogenicity, which refers to the potential of biologic drugs to provoke an immune response. This can affect the safety and efficacy of the drug. Physicians should monitor patients closely when switching from an originator biologic to a biosimilar, especially in the initial phases of treatment. 3. Pharmacovigilance. Close monitoring is required to detect any rare side effects or differences in long-term safety profiles between the biosimilar and the originator biologic. 4. Interchangeability. Some regulatory authorities allow interchangeability, meaning a pharmacist can switch between the reference product and the biosimilar without physician intervention. However, this is not yet universally accepted, and switching may require medical supervision in some regions. Differences between biosimilars, generics, and biocopy drugs. 1. Biosimilars versus generics. Biosimilars are to biologics what generics are to small molecule drugs, but there are critical differences due to the complex nature of biologics. Complexity. Biologics and biosimilars are large, complex molecules produced by living cells, while generics are small, chemically synthesized molecules that are exact replicas of the original drug. Development. Biosimilars undergo a rigorous development and approval process, including comparative clinical studies to demonstrate similarity to the reference product. Generics, on the other hand, only need to demonstrate bioequivalence, i.e., that they act in the body in the same way as the original drug. Production. Manufacturing biologics and biosimilars is much more complex than producing generics due to the involvement of living organisms, which introduces variability. 2. Biosimilars versus biocopies. Biocopies, or intended copies, are drugs that aim to mimic biologics but do not meet the strict regulatory standards of biosimilars. Biocopies are often produced in countries with less stringent regulatory oversight and may not have undergone the extensive comparative testing required for biosimilars. Regulation. Biosimilars are approved based on robust regulatory frameworks, e.g. FDA, EMA, and must demonstrate similarity in efficacy, safety, and quality to the reference product. Biocopies may not undergo the same stringent testing. Safety and efficacy. There may be significant concerns regarding the safety, efficacy, and immunogenicity of biocopies, as they are not held to the same standards as biosimilars. Summary table. Differences between biosimilars, generics, and biocopies. Feature biosimilars. Generics. Biocopies. Molecular structure. Complex, large molecules produced by living cells. Simple, small chemically synthesized molecules, similar to biologics but not identical. Similarly similar, with no clinically meaningful differences in efficacy safety, identical to the reference product, may not be rigorously compared to the original biologic. Approval process requires extensive comparative studies, efficacy, safety, immunogenicity, bioequivalent studies, same active ingredient, often lacks regulatory scrutiny. Regulation. Strict regulatory pathways, FDA EMA, follows standard regulatory pathways. Varied regulation, often not equivalent. Cost. Less expensive than originator biologics, but more than generics, usually much cheaper than branded drugs. Maybe cheaper than biosimilars, but risks are higher. Conclusion. Biosimilars provide a cost-effective alternative to biologics, expanding access to important treatments for autoimmune diseases, cancers, and more. While they are not identical to the original biologics, their high similarity and rigorous regulatory approval ensure they are safe and effective. However, their complex development, immunogenicity risks, and requirement for careful monitoring set them apart from generics. In contrast, biocopies should be used cautiously, as they do not meet the same regulatory standards as biosimilars. Immunogenicity is a major concern in the use of biological DMARDs, BDMARDs, due to their complex, protein-based nature. Immunogenicity refers to the ability of a drug to stimulate an immune response in the patient's body, leading to the production of anti-drug antibodies, ADAs. These antibodies can reduce the effectiveness of the biologic, alter its pharmacokinetics, and increase the risk of adverse events. The immune system may recognize biologic drugs as foreign proteins, especially because they are derived from living organisms, and mount an immune response against them. Why immunogenicity occurs in biological DMARDs. 1. Protein-based nature. Unlike small molecule drugs, biological DMARDs are large, complex molecules, such as monoclonal antibodies, fusion proteins, or receptor antagonists derived from living cells. Even slight variations in the structure of these biologics can trigger an immune response. 2. Non-human components. Some biological DMARDs contain components of non-human origin, such as murine, mouse, or chimeric, human mouse, monoclonal antibodies, which increase the risk of immunogenicity. 3. Post-translational modifications. Biologics often undergo post-translational modifications, like glycosylation, which may introduce variations in the protein structure, further increasing the risk of being perceived as foreign by the immune system. 4. Route of administration. Biologics are typically administered via injection or infusion rather than orally. This increases the likelihood of the immune system encountering and responding to the drug. Types of anti-drug antibodies, ADAs. 1. Neutralizing antibodies. These ADAs directly interfere with the drug's action by binding to its active sites or blocking its interaction with its target. Neutralizing antibodies significantly reduce the drug's therapeutic effect. 2. Non-neutralizing antibodies. These ADAs bind to the drug without blocking its action. However, they can still lead to rapid drug clearance, reduced efficacy, and increased risk of side effects. Clinical consequences of immunogenicity. 1. Reduced efficacy. The formation of neutralizing antibodies may render the biological DMARD ineffective, as the antibodies block the drug from binding to its target. This leads to a loss of clinical response over time, which can result in disease flare-ups or progression. 2. Increased drug clearance. Non-neutralizing antibodies can accelerate the clearance of the drug from the body, reducing its concentration in the bloodstream and leading to suboptimal therapeutic effects. 3. Adverse reactions. Infusion or injection reactions. Patients may develop acute infusion-related reactions, such as fever, rashes, or anaphylaxis, due to the immune response triggered by the biologic. Delayed hypersensitivity. Some patients may experience delayed immune-mediated reactions, such as serum sickness after repeated exposure to the biologic. 4. Cross-reactivity. In rare cases, ADAs may cross-react with the patient's own proteins, potentially triggering autoimmune reactions or worsening the underlying disease. Risk factors for immunogenicity in biological DMARDs. 1. Drug characteristics. Non-human origin. Drugs containing murine mouse components, such as infliximab, have a higher risk of immunogenicity compared to fully human monoclonal antibodies like adalimumab. Structural complexity. The more complex the biologic, e.g., monoclonal antibodies versus fusion proteins, the higher the likelihood of it being recognized as foreign. 2. Patient factors. Genetic factors. Genetic variations in the patient's immune system can affect the likelihood of developing ADAs. Disease state. Some autoimmune diseases are associated with a higher risk of immunogenicity, as the immune system in these patients is already primed for an exaggerated response. Concomitant immunosuppressive therapy. The use of immunosuppressive drugs, such as methotrexate or corticosteroids, alongside biologics can reduce the risk of ADA formation by suppressing the immune response. 3. Dosing and treatment schedule. Intermittent dosing. Inconsistent or interrupted dosing regimens can increase the risk of immunogenicity. Continuous exposure to the biologic at stable levels may reduce the likelihood of ADA formation. High drug concentrations. Higher doses or more frequent administrations can sometimes reduce the formation of ADAs due to a more constant drug presence, but this varies depending on the drug and the patient. Biological DMARDs with high immunogenicity potential. 1. Infliximab, Remicade, a chimeric, human mouse, monoclonal antibody that targets TNF-alpha. Infliximab has one of the highest rates of immunogenicity. Many patients develop anti-infliximab antibodies, leading to decreased efficacy and increased infusion reactions. 2. Adalimumab, Humira, a fully human monoclonal antibody targeting TNF-alpha. Adalimumab has a lower immunogenicity risk compared to infliximab, but still produces ADAs in some patients, particularly with longer treatment duration. 3. Etanercept, Enbrel, a fusion protein targeting TNF-alpha. Etanercept is less immunogenic compared to monoclonal antibodies like infliximab. However, non-neutralizing ADAs can still form, leading to reduced drug levels in the body. Strategies to manage immunogenicity. 1. Combination therapy. Administering biological DMARDs in combination with immunosuppressive agents like methotrexate or azathioprine can help reduce the formation of ADAs. This approach is commonly used with infliximab to mitigate its immunogenicity. 2. Optimizing dosing regimens. Maintaining a consistent dosing schedule with biologics helps ensure that drug levels remain stable in the bloodstream, which may reduce the likelihood of ADA formation. 3. Switching between biologics. If a patient develops ADAs to one biologic, they may be switched to another biologic with a different mechanism of action or molecular structure to avoid further immune responses. 4. Pre-medication. In some cases, patients may be pre-treated with corticosteroids or antihistamines to reduce the risk of infusion reactions and other immunogenic responses during biologic administration. 5. Monitoring ADAs. Routine monitoring of ADA levels and drug concentrations in patients undergoing biologic therapy can help guide treatment decisions, such as dose adjustments or switching therapies if the patient becomes resistant to treatment. Conclusion. Immunogenicity remains a significant challenge in the use of biological DMARDs in autoimmune diseases, as the immune system may mount a response to these complex protein-based drugs, resulting in the development of antidrug antibodies, ADA. This can lead to reduced drug efficacy, increased clearance of the biologic, and adverse reactions. Managing immunogenicity requires a multifaceted approach, including the use of combination therapies, careful dosing regimens, and close monitoring of patients. As more biosimilars and biologics are developed, addressing immunogenicity will continue to be a critical aspect of optimizing treatment outcomes for patients. The nomenclature of biological DMARDs, BDMARDs, follows a structured convention based on the type of biologic, its target, and its origin. This naming system, set by the World Health Organization International Non-Proprietary Names (INN) program, helps standardize the naming of these drugs globally. The names are often composed of several parts that provide information about the drug's source, target, and structure. General nomenclature structure. The typical structure for the nomenclature of biological DMARDs consists of the following components. 1. Prefix. The prefix is unique to each drug and is created for the purpose of branding and differentiation. It doesn't carry specific meaning, but helps distinguish the drug from others. 2. Substem A, target. This part of the name describes the target of the biologic drug, which could be a cytokine, immune cell, or pathogenic factor involved in disease. Examples: that cell M targets the immune system, e.g. adalimumab, ustekinumab. Kin targets interleukins, e.g. tilizumab, anakinra. 3. Substem B, source origin. This part indicates the source or origin of the antibody, providing information about whether the biologic is derived from human, murine, mouse, chimeric, or humanized proteins. Examples: O, mouse origin, e.g. tositumumab. Chimeric, human-mouse origin, e.g. infliximab. Zoo, humanized origin, e.g. tocilizumab. U, fully human origin, e.g. adalimumab. 4. Suffix. The suffix mab monoclonal antibody is commonly used for monoclonal antibody drugs. Other common suffixes: sept, fusion proteins, e.g. etanercept. Kinra, interleukin receptor antagonists, anakinra. Examples of biological DMARDs nomenclature. 1. Adalimumab, prefix, ADA, target, L immune system. Origin, NASH U, fully human. Suffix mab, monoclonal antibody. Meaning, a fully human monoclonal antibody targeting the immune system, specifically TNF-alpha. 2. Infliximab, prefix, in target, immune system. XZ, chimeric, HUMAB, monoclonal antibody. Meaning, a chimeric monoclonal antibody targeting the immune system, specifically TNF-alpha. 3. Etanercept. Prefix eden, target sept, fusion protein. Meaning, a fusion protein that acts as a TNF receptor blocker. 4. Tocilizumab. Toci, LIM, immune system. Origin, zoo, humanized. Suffix, mab, monoclonal antibody. Meaning, a humanized monoclonal antibody targeting the immune system, specifically the IL-6 receptor. 5. Anakinra. Prefix, ana, target kinra, interleukin receptor antagonist. Meaning, an IL-1 receptor antagonist. Understanding the origins. Substem B, drugs derived from murine mouse proteins, which are highly immunogenic due to their non-human origin. Example, tositumumab. Chimeric. These drugs combine mouse and human components, reducing immunogenicity compared to fully murine antibodies, but still presenting some risk of immune response. Example, infliximab. Humanized. Mostly human, with only a small portion of the protein derived from mouse. These drugs are less immunogenic than chimeric antibodies. Example, tocilizumab. Fully human. These drugs are entirely derived from human proteins, minimizing the risk of immune reactions. Example, adalimumab. Conclusion. The nomenclature of biological DMARDs is a systematic and informative method that provides key insights into the drug's target, origin, and function. Understanding these components allows healthcare providers to make more informed decisions regarding treatment choices, particularly in terms of immunogenicity risk and mechanism of action. Side effects and complications of biological DMARDs. Biological DMARDs are highly effective in treating autoimmune diseases, but they also carry risks of side effects and complications due to their immune modulating effects. The nature and severity of side effects vary depending on the specific biologic, the disease being treated, and individual patient factors. 1. Increased risk of infections. Mechanism. Biological DMARDs suppress specific components of the immune system, increasing susceptibility to infections. Common infections: upper respiratory tract infections, sinusitis, bronchitis, urinary tract infections. Serious infections: opportunistic infections such as tuberculosis, fungal infections, e.g. histoplasmosis, and herpes zoster. Some biologics, especially anti-TNF drugs, have a higher risk of reactivating latent infections like TB. Examples: anti-TNF agents, e.g., infliximab, adalimumab, high risk of TB reactivation, fungal infections. IL-6 inhibitors, e.g., tocilizumab, risk of severe infections and neutropenia. 2. Injection site reactions and infusion reactions. Injection site reactions, common with subcutaneous biologics, causing pain, redness, and swelling at the injection site. These are typically mild and transient. Infusion reactions occur during or shortly after intravenous administration of biologics. Symptoms can include fever, chills, rash, and hypotension. Examples: infliximab, IV anti-TNF agent. Infusion reactions are common and can be severe, including anaphylaxis. Etanercept, subcutaneous anti-TNF agent, can cause localized injection site reactions. Allergic or hypersensitivity reactions. Some biologics, especially chimeric or humanized antibodies, can trigger allergic reactions. Symptoms range from mild rash to life-threatening anaphylaxis. Examples: infliximab, chimeric anti-TNF, higher risk of hypersensitivity reactions due to its murine component. Tocilizumab, known to cause hypersensitivity, including anaphylaxis in some patients. 4. Malignancy risk. There is concern that biologics, particularly anti-TNF agents, may increase the risk of certain cancers due to long-term immune suppression, though the data remains inconclusive. The risk is higher for lymphoma and non-Hodgkin cancers. Examples: anti-TNF agents, slightly increased risk of lymphoma, especially in patients with long-standing autoimmune diseases. 5. Cardiovascular complications. Some biologics, like TNF inhibitors, may increase the risk of heart failure or exacerbating heart failure. Examples: infliximab, contraindicated in patients with moderate to severe heart failure due to the risk of worsening symptoms. 6. Blood gradients. Biological DMARDs can cause abnormalities in blood cells, including anemia, neutropenia, and thrombocytopenia. These effects can be severe and may require discontinuation of drug. Examples: tocilizumab, IL-6 inhibitor, can cause neutropenia and thrombocytopenia. Rituximab, anti-CD20, known for causing severe blood cell count abnormalities, including prolonged neutropenia. 7. Rare biological DMARDs can trigger autoimmune conditions like drug-induced lupus, vasculitis, or psoriasis in patients treated for other autoimmune conditions. Examples: etanercept, anti-TNF, can paradoxically induce or worsen psoriasis. Liver toxicity. Biological DMARDs, especially TNF inhibitors, can cause elevated liver enzymes and increase the risk of drug-induced liver injury. Examples: adalimumab, anti-TNF agent, can cause mild to moderate elevation in liver enzymes. 9. Demyelinating diseases. Anti-TNF agents have been associated with the development or worsening of demyelinating disorders, such as multiple sclerosis, MS. Etanercept and infliximab have been linked to cases of new-onset MS-like symptoms or worsening of pre-existing demyelinating diseases. Precautions with biological DMARDs. 1. Screening latent infections, tuberculosis. Before starting biologics, particularly TNF inhibitors, patients must be screened for latent TB using a tuberculin skin test or interferon gamma release assay, IGRA. Those with latent TB should be treated before biologic initiation. Hepatitis B and C. Screening for hepatitis B and C is recommended, especially in patients from high-risk populations. 2. Immunization. Patients should receive recommended vaccines, e.g., flu, pneumococcal, hepatitis B, before starting biologics, since live vaccines are contraindicated during therapy. Live vaccines, e.g., MMR, varicella, should not be given while on biological DMARDs due to the risk of uncontrolled viral replication. 3. Monitoring for infections. Patients on biologics should be monitored closely for signs of infection and advised to seek medical attention for any signs of fever, chills, or persistent cough. 4. Regular blood testing. Patients should undergo regular blood tests to monitor for changes in blood counts, liver enzymes, and renal function. 5. Heart failure monitoring. For patients with pre-existing heart failure, caution is advised when using TNF inhibitors. Alternative therapies should be considered for patients with severe heart failure, NYHA class 3-4. Contraindications of biological DMARDs. 1. Active infections. Biological DMARDs are contraindicated in patients with active infections. Patients should not start biologic therapy if they have an ongoing infection, including sepsis, abscesses, or uncontrolled chronic infections. 2. Tuberculosis. Active or untreated latent tuberculosis is a contraindication for biologics, especially TNF inhibitors, as they can lead to TB reactivation and dissemination. 3. Chronic hepatitis B. Biological DMARDs, particularly TNF inhibitors and rituximab, are contraindicated in patients with untreated hepatitis B as they may lead to reactivation of the virus. 4. Demyelinating diseases. Patients with a history of multiple sclerosis or other demyelinating diseases should avoid TNF inhibitors, as they may exacerbate or trigger neurological symptoms. 5. Heart failure. TNF inhibitors, e.g., infliximab adalimumab, are contraindicated in patients with moderate to severe heart failure due to the risk of worsening symptoms. 6. Malignancy. In patients with a history of certain cancers, such as lymphoma, the use of biologics, particularly TNF inhibitors, should be approached with caution or avoided due to the potential increased risk of cancer recurrence. 7. Pregnancy and breastfeeding. Most biologics are classified as category B or C in pregnancy, meaning there may be risks, particularly during the third trimester. However, some biologics, e.g., certolizumab pegol, are considered safer in pregnancy. Biologic use during breastfeeding is generally not recommended due to the lack of safety data. Summary. Biological DMARDs offer significant therapeutic benefits in the management of autoimmune diseases, but come with a risk of serious infections, malignancies, blood disorders, and autoimmune reactions. Proper screening, monitoring, and patient education are essential to mitigate risks. Biological DMARDs are contraindicated in active infections, untreated latent TB, chronic hepatitis B, and certain other conditions like severe heart failure and demyelinating diseases. Future insights for biological DMARDs in rheumatology. The future of biological DMARDs, BDMARDs, in rheumatology is promising, driven by advances in biotechnology, genetics, precision medicine, and biosimilar development. These innovations are expected to enhance the efficacy, safety, accessibility, and personalization of treatments for autoimmune and inflammatory diseases. 1. Personalized medicine and precision therapies. Tailored treatment plans. Advances in genomic profiling and biomarker discovery will allow for more personalized approaches in selecting BDMARDs, ensuring that each patient receives the most appropriate therapy based on their specific genetic and immune system characteristics. Predicting treatment response. Using biomarkers to predict which patients will respond well to specific biologics, e.g., anti-TNF, anti-IL-6, can help avoid trial and error prescribing, reducing unnecessary exposure to side effects, and optimizing disease control. Immunoprofiling. The development of comprehensive immune profiling will allow clinicians to categorize patients more accurately and predict how they will respond to particular biologics, improving outcomes. 2. New biologics with novel mechanisms of action. Targeting new pathways. Researchers are investigating newer biological pathways and molecular targets beyond TNF and interleukins that play crucial roles in autoimmune diseases. Antigranulocyte macrophage colony stimulating factor, GM-CSF. Agents like mavrilimumab target GM-CSF, which is involved in inflammatory processes in diseases like rheumatoid arthritis. Anti-B cell activating factor, BAFF. Drugs like belimumab are being developed to target BAFF, a key player in B-cell survival and autoimmunity in diseases like lupus. Anti-CXCL10. This chemokine is implicated in various inflammatory conditions, and targeting it could yield new therapeutic options. Dual-action biologics. The development of bispecific antibodies, capable of targeting two different cytokines or cell receptors, is another exciting area. These drugs could potentially provide more effective disease control by simultaneously blocking multiple disease pathways. 3. Biosimilars and biobetters. Biosimilar expansion. The market for biosimilars is growing rapidly. Biosimilars offer more cost-effective alternatives to original biologics, making treatment more affordable without sacrificing efficacy. As patents on more biologic drugs expire, additional biosimilars for drugs like atacicept, tocilizumab, and others will be developed. Biobetters. These are enhanced versions of existing biologics, modified to have better pharmacokinetics, reduced immunogenicity, or improved efficacy. For example, longer-acting biologics with less frequent dosing schedules are likely to be developed to improve patient adherence. 4. Oral biologics. The development of oral biologics that can replace injectable or intravenous formulations is a highly anticipated area of innovation. Oral formulations may increase patient compliance, reduce administration related complications, and lower healthcare costs associated with infusion therapies. Advances in drug delivery technologies, such as nanoparticle based delivery systems, could allow biologics to be absorbed effectively through the gastrointestinal tract. 5. Combination therapies and sequential therapy. Combining biologics. There is increasing interest in combining biologics targeting different pathways. While this approach has historically been avoided due to the risk of immunosuppression, future advances may identify safe combinations that provide more comprehensive disease control. Sequential therapy, exploring the optimal sequence in which biologics are administered, is another focus area. Studies may reveal whether starting with one biologic and transitioning to another after disease stabilization could lead to better outcomes or lower risks of side effects. 6. Reduced immunogenicity. Advances in protein engineering. Newer biologics are being engineered to have lower immunogenicity, reducing the likelihood of patients developing anti-drug antibodies, ADAs, that can neutralize biologics or cause adverse reactions. Non-antibody biologics. Non-antibody-based biologics, such as small interfering RNA therapies, are being explored to minimize immune system activation and side effects associated with monoclonal antibodies. 7. Real-world data and artificial intelligence. Real-world data. Utilizing data from patients in real-world settings outside clinical trials will help refine treatment approaches, identify long-term safety signals, and determine optimal dosing and drug switching strategies. Artificial intelligence, AI. AI-driven tools can assist clinicians in predicting disease flares, identifying the best biologic based on individual patient data, and optimizing treatment regimens based on real-time patient monitoring. 8. Potential for disease modification. Some biologics show potential not only in controlling symptoms, but also in achieving disease modification, meaning they may alter the underlying disease process to induce long-term remission or even cure. Research in this area aims to explore the use of biologics earlier in disease progression to potentially change the course of autoimmune conditions like rheumatoid arthritis or systemic lupus erythematosus. 9. Gene therapy and cellular therapies. Gene editing technologies, e.g., CRISPR, could one day provide targeted and permanent solutions for correcting genetic mutations associated with autoimmune diseases, reducing or even eliminating the need for lifelong biologic therapies. CAR T-cell therapy, already showing promise in cancer treatment. Chimeric antigen receptor T-cell, CAR T therapy, is being explored for autoimmune diseases. The aim is to reprogram the patient's T cells to selectively target and destroy disease-causing immune cells. 10. Addressing safety concerns. Future developments will focus on reducing long-term side effects, particularly the risk of infections and malignancies. Strategies may include using smaller doses, safer combinations, or biologics with shorter half-lives that provide flexibility in managing adverse events. Conclusion. The future of biological DMARDs in rheumatology is marked by exciting innovations, particularly in personalized treatment, biosimilar development, and the introduction of novel targets. As biologic therapies evolve, they are expected to become more precise, effective, and accessible, potentially altering the landscape of autoimmune disease management. With advancements in genomics, AI, and gene therapy, biologics may not only control disease, but also bring us closer to disease remission or cure. Biological drugs, though primarily known for their use in rheumatic diseases, are widely used across various non-rheumatic indications due to their ability to target specific molecules involved in disease pathways. These biologics have revolutionized the treatment of several conditions, including autoimmune diseases, cancers, inflammatory conditions, and genetic disorders. Here's an overview of biological drugs used in non-rheumatic indications. 1. Dermatological diseases. Psoriasis, biologics targeting TNF alpha, IL-17, IL-12, IL-23-3, and IL-23 pathways are commonly used. Etanercept, adalimumab, infliximab, anti-TNF agents, ustekinumab, anti-IL-12, IL-23, secukinumab, ixekizumab, anti-IL-17, guselkumab, risankizumab, anti-IL-23. Atopic dermatitis, dupilumab, targets IL-4 and IL-13 and is used for moderate to severe atopic dermatitis. Hidradenitis suppurativa, adalimumab, approved for use in this chronic inflammatory skin condition. TATU, gastrointestinal diseases, inflammatory bowel disease, Crohn's disease, and ulcerative colitis are treated with biologics targeting TNF, integrins, and interleukins. Infliximab, adalimumab, certolizumab pegol, anti-TNF agents. Vedolizumab targets integrin I4 of beta-7, reducing gut-specific inflammation. Ustekinumab, approved for Crohn's disease, targets IL-12, IL-23. Celiac disease, under research. Biologics like anti-IL-15 agents and immune-modulating antibodies are being explored to manage refractory celiac disease. Oncology, cancer immunotherapy. Monoclonal antibodies are widely used in oncology to target specific cancer cell markers or enhance the immune system's ability to attack cancer cells. Rituximab, anti-CD20 monoclonal antibody used in non-Hodgkin's lymphoma and chronic lymphocytic leukemia. Trastuzumab targets HER2 receptors used in HER2-positive breast cancer. Bevacizumab, anti-VEGF, used to inhibit angiogenesis in cancers like colorectal cancer and non-small cell lung cancer. Pembrolizumab, nivolumab, PD-1 inhibitors used in melanoma, lung cancer, renal cell carcinoma, and other cancers. Ipilimumab, CTLA-4 inhibitor used in metastatic melanoma. Neurological diseases, multiple sclerosis, MS. Biologics that modulate the immune response are used to slow disease progression. Natalizumab targets I4 integrin used to prevent immune cell migration into the brain and spinal cord. Ocrelizumab targets CD20 on B cells, approved for relapsing and primary progressive MS. Alemtuzumab targets CD52 and depletes lymphocytes, used in relapsing remitting MS. Alzheimer's disease, under research. Aducanumab, approved to target amyloid beta plaques in Alzheimer's disease, although its effectiveness remains debated. 5. Respiratory diseases. Asthma. Biologics targeting IgE, IL-5, and IL-4, IL-13 are used in severe asthma that is unresponsive to conventional treatments. Omalizumab targets IgE, used in allergic asthma. Mepolizumab, benralizumab, reslizumab target IL-5, used in eosinophilic asthma. Dupilumab targets IL-4 and IL-13, used in severe asthma with high eosinophils. Chronic obstructive pulmonary disease, CO, benralizumab, and mepolizumab are being studied for severe COPD with eosinophilic phenotype. 6. Ophthalmological diseases. Age-related macular degeneration, AMD, ranibizumab, bevacizumab, and aflibercept. Target VEF, used to prevent abnormal blood vessel growth and leakage in the retina, a key feature in wet AMD. Diabetic retinopathy and macular edema. VEGF inhibitors like ranibizumab and aflibercept are used to treat diabetic retinopathy by preventing vascular complications in the retina. 7. Endocrine disorders. Diabetes mellitus type 1. Teplizumab, anti-CD3 monoclonal antibody recently approved to delay the onset of type 1 diabetes in high-risk individuals. Osteoporosis. Denosumab targets RANKL, used to inhibit bone resorption in osteoporosis and bone metastasis-associated cancer. 8. Cardiovascular diseases. Hypercholesterolemia, evolocumab, alirocumab. These monoclonal antibodies target PCSK9, significantly reducing LDL cholesterol levels in patients with familial hypercholesterolemia or those unresponsive to statins. Atherosclerosis, under research. Canakinumab, an IL-1 beta inhibitor, has shown promise in reducing cardiovascular events in atherosclerosis in the CANTOS trial, though it is not yet widely approved for this indication. 9. Genetic disorders. Cystic fibrosis. Elexacaftor, tezacaftor, ivacaftor. This combination therapy is a targeted biologic treatment for patients with specific CFTR mutations, improving lung function and quality of life. Spinal muscular atrophy. Nusinersen, a biologic that modifies SMN2 gene expression used to treat patients with SMA. 10. Hematological disorders, hemophilia. Emicizumab, a bispecific monoclonal antibody mimicking factor VIII used in patients with hemophilia A with or without factor VIII inhibitors. Paroxysmal nocturnal hemoglobinuria, PNH. Eculizumab targets complement protein C5, preventing red blood cell destruction in patients with PNH. Aplastic anemia, a thrombopoietin receptor agonist, stimulates platelet production in severe aplastic anemia. 11. Infectious diseases. COVID-19, tocilizumab, anti-IL-6, used to control the cytokine storm associated with severe COVID-19 pneumonia. Sotrovimab, casirivimab, imdevimab, monoclonal antibodies targeting the SARS-CoV-2 spike protein used in preventing severe COVID-19 in high-risk patients. HIV, ebalizumab, a monoclonal antibody used in multi-drug-resistant HIV infections. It targets CD4 and prevents HIV from entering host cells. Conclusion. Biological drugs have greatly expanded beyond rheumatology, finding applications in dermatology, gastroenterology, oncology, neurology, and other medical fields. These targeted therapies offer significant benefits by modulating specific molecular pathways, leading to more effective treatments with fewer side effects than traditional therapies. As research advances, the scope of biologics will likely continue to broaden, offering new hope for previously untreatable conditions.